I think that'd be a great question. Go ahead. I'll start down at the end. Dude.
Rick, I got a couple of things I want to talk about. I apologize if I'm going to take too much time. I want to clarify one remark I had on nutrients. And, what Dr. Ureth said is right. It's impossible to get the nutrients that we need from food, but it's also impossible for most people to afford to buy the supplements that they need. When I mentioned you need 1,000 milligrams of magnesium per day, I have a double chelate capsule that I buy. There's 125 milligrams of capsule. That's a lot for a guy to take. So, a supplement is only that, a supplement to what should be an already healthy diet and organic nutrition. But Rick, the point you brought up, just this year, owning a compounding pharmacy, I got fired from one of my wholesalers. Why? This is what's going on in the world when it comes to testosterone therapy right now. It's about ratios of purchases as an independent pharmacy. So I don't take any insurance. If you don't know, if I did take insurance like a Walgreens and CVS, I'd lose money on 7 out of 8 claims. I'd lose money because Walgreens, CVS, Walmart, they own all your top PBMs, your prescription benefit managers. So now when you look, well, what do I buy? I'm not buying blood pressure meds. I'm not buying normal diabetes meds. I'm buying a lot of testosterone. I compound the testosterone. And I get orders for either one. And when you look at my purchases of controlled substance to non-controlled substance, the DEA has just said, in collaboration or collusion with the FDA, has said, we don't want pharmacies to buy more than a 4-to-1 ratio of non-controlled to controlled substance. So testosterone is the controlled substance. Now, I got a letter from AmerisourceBergen and said, well, due to the CDC's declaration of a prescription abuse epidemic, so pay attention to that language, not an opiate epidemic, which is horrible, right? Before we even get into the fentanyl, right, that's coming across the border, just the oxys, right, the opiate epidemic, it's prescription abuse epidemic, and it's the CDC. So this triggers the top 3 wholesalers to pharmacies to say, well, let's put in controls. The average pharmacy, the 25,000 chain drugstores, they have a 4-to-1 ratio, non-control to control. But these guys are outliers, like mine. I'm 1-to-1 because I dispensed so much testosterone. So I got fired. You know what? Our risk management department just decided we're not gonna take you on. I'll ask you later. I don't know. Is that tortious interference? Right? Because it's like, well, why? They made a judgment to say, well, we don't have to give you a reason. Risk management says no. But, the interesting thing, now back on the topic of the trends in testosterone therapy, because one thing I pay attention to in regard to the trends are the temporal changes in lab values that have occurred over the last 30 years. So all the physicians know that what's considered normal range is typically based on your most recent 150,000 samples according to a particular region for the major labs. And there is a bell curve established. And if you're the lower standard deviation, the bottom 5%, well, you're low. And if you're the highest standard deviation, you're at the top. Oh, you're high, right? Oh, if you're high, you're going to drive cardiovascular risk. Now, the data clearly shows, yes, red blood cell proliferation is a natural phenomenon with testosterone. It's often why fatigue improves. Where do the risk factors begin? There's not a risk factor but the risk factors may begin when your hematocrit is above 55, hemoglobin over 18.5. That's published in a number of cardiovascular journals. Clinically speaking, since, Nick, you mentioned the diabetics, okay? Testosterone, so many studies, even from Kaiser. Low testosterone, take it to high normal, 20% reduction in mean blood glucose. Yeah. So how much, glucose disposal is activated? And who wants to go work out when they're the typical picture of andropause, man over 50, which is a lump on the couch that women would typically refer to as their husband? Because this happens. Well, what were we talked about it. The biggest driver of knowledge about testosterone therapy has actually been women. Why? Because Suzanne Somers wrote her books, and women said, I don't want these synthetic estrogens. I want to feel better. And when you give a woman a whiff of testosterone, which was antithetical to the current pharmaceutical model at that time, which was, well, a hot flashes, let's just give them estrogen and a progestin, which is not even progesterone. But you reduce breast cancer risk in women when you replenish their testosterone to a youthful level by significant amounts. You have half the breast cancer risk in women when you give them testosterone supplementation to youthful levels than you do for women who have never used any form of hormone therapy whatsoever. Similar trends are happening in men because we're seeing prostate cancer develop at a younger age than ever. We see testosterone is lower at a younger age than ever. We see sperm count is reduced. So what's normal now on a lab report, well, let's just compare it to 2005 when they entered the market. Normal range for testosterone would be 300 to 1,000 on a total for men. Now the normal's a little bit lower, 280 to 900. And 30 years ago, the top end of normal would be 1,200. That's a 30% reduction. Now, the total testosterone is not the only measure. Well, we can talk later about free androgen index, sexual blah, 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 how we address that. But what's happening with back to food now is our foods are so polluted with endocrine disruptor chemicals. Most of them are similar in structure to estrogen, and there's only, 80,000 that we've classified in our environment. How about touching the thermal receipts? And you get bisphenol A absorbed through the skin. So the question is, well, yes, we need testosterone for health. That's clear. I was talking before this lecture began saying, as a cynical pharmacist who used to work in the drug industry, I did over 10 years clinical research, virology, infectious disease, but I could show a slide with all the symptoms of androgen deficiency in men and women and point out where I could get 6 prescription drugs out. And this is called, this whole spectrum of medicine, which begins with hormones or nutrition, is called the alternative, right? I say, no, it's not. The alternative is when you take a man-made molecule that has never been in the human body, you make a drug out of it because you can patent it, and then you use that for therapeutic effect. So risk-benefit analysis, I think, is crucial, and I will stop and let the doctors talk. But, the data is clear with regard to risk. Is there risk? Sure. Where does the risk begin? You have to try really hard. And Boulder, Colorado, high elevation states, how many men walk around with a hemoglobin of 17 and feel just fine? Yeah, it's not just the hemoglobin hematocrit, as you know, that's the only way. Let's talk about insulin. We have to talk about inflammation. Issue that I'd like to see addressed is I'd like to see as many people as possible have optimal youthful hormone levels at any age. Now, whether or not that means go straight to testosterone replacement, use nutritional interventions or some other interventions to do that, that's a whole different spectrum. But what I've seen as far as the trends too is, you're right, men in their 20s now with total testosterone have come in at 200. Sometimes there are women in their 20s that happen to be athletes that have a total testosterone of 200. So I just wanted to speak to the cardiovascular because I'm very familiar with those. And I also made all of the subcutaneous testosterone pellets for a 10-year prospective trial. Woman with in collaboration with a Greek partner, Constantine Dimitrakakis, or Rebecca Glazer, studied over 1,300 women for testosterone replacement therapy. 314 of them had a previous personal history of breast cancer. So we would typically expect ASCO, American Society for Chemotherapy Cancer Oncology. They measured the incidence of breast cancer in person years, right? So for women who use conventional hormone therapy without testosterone, your incidence is about 300, 360 per 100,000 person years. For the never users of testosterone, it's about 215 never users. For those who use testosterone, it's 73. So you have a dramatic risk reduction. And vitamin D, yes, too, because 50% risk reduction of breast cancer. When you have an optimal vitamin D level, we looked at that 314 set of women. So in most breast cancer cell lines, I get a question a lot about, what about hormones for breast cancer as far as risk? What about hormones for prostate cancer as far as risk? Let me just speak to the breast cancer one right now to cut my time shorter. For women with previous history, we cut the risk down to 0 recurrence when we used testosterone in combination with an anastrozole. That was a unique little thing. We put a whiff of an anastrozole in subcutaneous pellets. That was Rebecca Glazer's chosen route of administration. We do see really good clinical outcomes with it, but there was 0 recurrence in women who had a previous history. And what's one of the reasons why? Most breast cancer cell lines, the vast majority, have androgen receptors. When they're androgen receptor positive, and you shower that androgen receptor with testosterone, you induce apoptosis in every breast cancer cell line that expresses the androgen receptor. In the breast cancer cell lines that do not express the androgen receptor, which is very few of them, thankfully, it's a very aggressive, fast-developing cancer that we're having a hard time treating. So I like to talk about the benefits versus the risk. And there's some very proven clinical benefits in the research literature that, no, it's not dangerous. It's dangerous to keep your androgen level low. No. What the method of replacement is, that's what you talk to the good doctors about.
It's interesting, your story at the pharmacy, because my pharmacy, the Hormonist, we do what we say on the tin. It's the Hormonist. That's all we do, really, are hormones, in particular testosterone. And with our wholesaler, the manufacturer, we were getting the main testosterone product in the UK, Testosterone, from the manufacturer, but it wasn't very profitable for them. So essentially they shifted it to just one wholesaler in all of the UK who could supply this licensed drug. We had to show thousands and thousands of redacted prescriptions You have to manually redact every prescription so the patient's name isn't on there. I sent them as kind of a gesture of goodwill, the sheet of all the orders that we had at the pharmacy, because sometimes the prescription, the patient will be prescribed 6 or 7, and then might not have the money to buy the full 7 ampules, so they'll get 3 or 4 ampules. So we just showed out like this is what we used in a week. That set off alarm bells. I mean, just the fact that we had so much volume set off alarm bells. We had our pharmacy, had to get lawyers involved. It was a mess. Finally, after months of sweating, as my patients wouldn't get any of their medication, I even called the head of the pharmacy regulator. I said, look, can you help us out here? He said, no, we're not here to help. We're here to regulate you. Thousands of patients won't get their prescription for testosterone. This is a serious medical issue that the regulator should look at. If you can't help me, should I just give them your phone number and your contact details, and maybe you can address their concerns? So a week later, I get a letter from the GPHC saying, we didn't appreciate your aggressive tone with us. That's a very British thing, see. So I can completely empathize and see finally we did get our supply. As it goes now, there's a small shortage this week, but I'm sure we've got plenty of to get through it. But yeah, it's so frustrating. And I think it goes back to the stigma around testosterone. They don't understand. I mean, this responsible person, she didn't have a clue. She didn't understand how it worked. And in fact, when they did get the trigger, it went to the MHRA, which is like the FDA, and then they put out an all-points bulletin to all the other regulators. So even our clinic side, when we had our inspection, they asked us, what's this all about? And they still didn't get it. Finally, there happened to be an intelligent pharmacist that was along with the regulator, that actually understood and said, no, these guys are fine. Everything is good. But yeah, it seems like they're coming after testosterone, and we've seen it from the endocrinology side in their societies. They've got a problem with testosterone being mainstream, and they're not seeing it as a benefit for your general health and wellness. And like you guys have said in the studies, low testosterone is more dangerous than having optimal testosterone.
Here's a practitioner here, like how that's looking in your practice as far as, testosterone helping people and risk-benefit ratio there.
When you look at it as a physician prescribe it, testosterone is a scheduled drug. That means when I submit a prescription for it, I have to actually do it in a very particular manner. I get registered every script I put in. So exactly the same as if I was prescribing oxycodone, an opioid. It falls in that exact same category, which is sad, right? I mean, certainly. So when I get these lists of how many times I'm prescribing a controlled substance, whether it's an opioid, dangerous, or testosterone going into your life, and get this list. You are an overprescriber of a scheduled drug. So as a physician, when you're getting these lists and I prescribe a lot of testosterone. So certainly if you pull me in from other, particularly orthopedists, right, I'm going to look really excessive. And yet the other orthopedists are handing out opioids like candy. I'll hand out testosterone like candy. So it is tough, and you have to be able to kind of fight those battles and defend yourself. I will use testosterone a lot in both women and men for healing and recovery. So for instance, nandrolone, a very potent anabolic, right? 12-to-1 anabolic to androgenic ratio. It is great for healing. Study after study. 30 years ago, we used nandrolone for treating osteoporosis, for treating injuries. If you take somebody and do a total joint replacement on them and put them on nandrolone afterwards, they'll heal 3 times as fast. If you take your little osteoporotic woman who fractures her vertebrae and you put her on nandrolone, she's going to heal much more rapidly. And I can actually much more easily bring her bone density up using drugs like nandrolone. And yet that's nandrolone is a scary drug. If you read about it, people are like, oh my God, they're doing nandrolone? So you really are fighting a lot of stigma here, and yet these are so incredibly powerful for healing and recovery, not just longevity. And in my business, we're doing both longevity medicine and trying to help people get through injuries, both athletes and non-athletes. So I take these very high-level athletes. And then to say, when you're working with high-level athletes, and these are drugs that are, you can't use, right? And yet I have these athletes that I have to get to recover. You also, when you look at and I feel sorry for men. It is hard to be a man today. It is. And it is. I mean, honestly, you're trying to walk this fine line between not pissing off women and Yeah. It is really, really hard. Whereas women can be, we can be feminine, we can be masculine, you can be anything. It's great. And then you've got to be, I got to just walk this. It is hard to be a man. I feel sorry for my sons. It is really hard to be a man today. from the female perspective, I think that women are being horribly abused by birth control pills. So we have handed out birth control pills like they're candy to 13-year-old girls. And if you look at the biggest testosterone disruptor, birth control pills will give you massive amounts of estrogen, raise sex hormone binding. Well, I mean, those women have zero testosterone, none. And it's very hard to get it back once you even get them off the birth control pills. So we're handing out these birth control pills, and their testosterone levels are blunted to nothing. And then we're expecting them to be able to heal and recover, or these athletes who are on birth control pills. So there's a lot that we have to be able to look at in terms of utilizing these medications, things that really are critical to healing, critical to our longevity, and not putting a stigma on every physician who utilizes them in that much higher concentration.
George has a story about his grandmother, right?
Yeah.
Will you touch the microphone? Yeah.
Yeah, so my grandmother, she passed at 108.
108 years old, yeah.
So from she got a pneumonia and out of COVID, of course. And so the last 2 years spent in taking on the bed, laying down. But the point is, with DECA, 100 milligrams every 2 weeks. Like my sister, who's also a pediatrician, open-minded, she follows my career. Her husband is a cardiologist, more close-minded, So he said, it's up to you guys to do it. But unofficially, of course, while she was hospitalized. So we applied here DECA. This reversed the wasting syndrome.
It's dramatic, right?
Yeah. Hematocrit went to 41.
Right.
Of course, 0 bone fractures all her life. Yes, my sister was taking the DECA from the pharmacy. She was injected it. A bit of acne, but this is minor thing, okay? And I was once in a congress of orthopedics as a guest of a friend of mine. And I asked the question, said, do we use DECA in bone fractures? And they said it's not our first option. I would have other alternative drugs in order to increase the bone mineral density and heal up the bone fracture rather than using nandrolone, which is a third choice, let's say.
Well, and these other drugs, which actually are teriparatide, which is expensive, hard to get, and not nearly as anabolic as nandrolone.
I'll make a quick comment as a confessions of a guy who used to work in the drug industry, and I'm the cynical pharmacist these days, because as I hear the physicians talking, well, if I was a pharmaceutical executive, I'd say, you want to use nandrolone for healing? We have Boniva. Salad Field. We started getting on that, right? But now that those drugs, they don't build bone properly, so abnormal picture is going to be more severe. But no, we spend money on the advertising. And next choice, yes, you mentioned potently elevating the hematocrit, desirable in those patient population.
I need that.
How many patients could we have avoided the use of very expensive erythropoietin?
Right.
Because nandrolone is money from prescription. Correct, because nandrolone is big pharma doesn't like it. It's only $5. When I have my own colleagues, now I'm 51. Oh, you still doing testosterone? I still do stuff, I take this stuff.
Yeah.
Martial arts, I'm like, what are you doing? One of these lumps on the couch. Why don't you do that? And it's like, if you want to heal, you want to put yourself in a healing mode. Let's talk about, at least evaluating your hormones. But there's so much in regard to, like I said before, androgen decline in both sexes, lots of drug utilization, and what Dr. Yurti said about the birth control pills. What's one of the reasons? If you don't drink it in municipal water, but you shower in it without filtering it, where does all the recirculated birth control pills and antidepressants, top 3 drugs in your municipal water system, oral contraceptive pills, your cholesterol drugs, and antidepressants. Can you absorb hormones through the skin? I make hormone creams all the time. Absorbing that in a hot shower when you breathe it in through the lungs, just something to think about, because what I really hope is going to be more addressed. And this panel is very different, the medical practitioner in particular, to the ones out in the community here. I serve Las Vegas and other communities that are just dipping their toe in this hormone therapy water. And they'll tell you about the estrogens, the synthetics, and the naturals, elevating sexual hormone binding globulin. That's how birth control pills get rid of acne, right? Yeah. Swallow the estrogen in my mouth, sexual hormone binding globulin goes up, acne goes away because the androgen effect is gone, and aging accelerates right then and there in that woman's body. And that's where the risk of certain cancers begin, because of that androgenic and estrogenic ratio. Right. Doctors know.
Yeah, and let's go back to the cardiovascular, possibly of cancer risk. Why are not 20-year-olds getting cardiovascular disease and cancer, right? They have massively higher levels of testosterone. Why are we getting this when guys are 70, 80? People, all you have to do is sort of look at what makes sense in life and say it's not a risk. Now, I do think one of the keys is understanding metabolism of these hormones, right? So if they're metabolizing for both cancer and probably cardiovascular risk, looking at how people are potentially metabolizing some of these hormones is probably important. For instance, if everything you're giving is going into a 4-hydroxyestrone, 4-hydroxyestrone is a bad estrogenic pathway. And when you're just measuring estradiol in blood, you can't really see 4-hydroxyestrone.
Estrone.
So you have to look at, so we follow urine metabolites regularly on our patients who we have on high doses of hormones, and we can see that we're not forming, so 4-hydroxyestrone is an oxidative free radical. It damages DNA, it's linked to cancers, it's linked to cardiovascular disease, it's an oxidative free radical. So if you can monitor those, and you can do simple things, you can use things like diindolylmethane, DIM, which is what's in broccoli and cauliflower. You can use calcium D-glucarate. You can use simple things to modify those.
So is it better to use estrogens with DIM instead of estrogen?
Right, yeah, exactly. DIM is great for that, right. And even in men, DIM is helpful, to some degree. It might be too estrogen blocking, but you have to be careful. But
Good shit.